Vasculitis is characterized by the inflammation of blood vessels. It may occur in any organ system of the body. Cutaneous vasculitis, the lesions of which are polymorphous, can be skin-limited disease, primary cutaneous vasculitis with secondary systemic involvement, or a cutaneous component of a systemic vasculitis. Generally, the size of vessel involvement correlates with clinical morphology. Small vessel vasculitis involving the superficial dermal vessels typically manifests as palpable purpura, although they can also manifest as hemorrhagic vesicles, urticarial lesions, or rounded ulcers. These, in turn, can coalesce into larger purpuric areas. Inflammation accounts for the symptomatology, the burning, itching, or pain experienced by the patient. The effect of gravity on immune complex deposition accounts for lesion distribution in dependent areas like the lower legs and buttocks. Medium vessel vasculitis, which involves deep dermal or subcuticular vessels, also results in purpura, but lesions are typically larger, more destructive, and irregularly shaped. Findings such as subcutaneous nodules, livido-racemosa, jagged ulcers, and digital necrosis are common. Large vessel vasculitis affects large arteries like the aorta and its major branches. The two main types are Takayasu and giant cell arteritis. Differentials are broad since the presentation is so varied. Included in the differentials are thrombocytopenic purpura, trauma, scurvy, disseminated intravascular coagulation, septic emboli, erythematosus embolism, and calcinosis cutis. Addressing the inciting etiology may alone be effective. If it's a drug, stop the drug if possible. If it's associated with infections or malignancy, you may treat the underlying disease. Conservative measures, including rest, elevation, and use of compression stockings, help prevent immune complex deposition in the lower extremities and aid in wound healing. Topical steroids and moisturizers can help address pruritus and other local skin symptoms, though they do not prevent new lesions. NSAIDs may help address skin discomfort and arthralgias when present. Since most cases of isolated cutaneous vasculitis are self-limited and resolve spontaneously, most patients require no systemic treatment. For those with severe, intractable, or chronic and recurring disease, systemic therapy is indicated. Unfortunately, no robust body of literature is available to guide management, and therapeutic recommendations are based mostly on case reports, case series, and expert opinion. For systemic vasculitis, glucocorticoids are always used, initially at high doses for severe disease, and additional immunosuppressive medications depend on the type of vasculitis, extent of disease, and comorbidities of the patient.